substitute chair to the Financial Technical Advisory Committee will now call the meeting to order.
Welcome, FTAC members. It's now 2:02 p.m. and I call to order FTAC's July 11th meeting. We will begin with a land acknowledgement. I am in Seattle on the ancestral land of the Duwamish people. I'm sharing their suggested land acknowledgement. I would like to acknowledge that I am on the traditional land of the first people of Seattle, the Duwamish people past and present, and honor with gratitude the land itself and the Duwamish tribe. It is important to note that this kind of acknowledgement is not a new practice developed by colonial institutions. Land acknowledgement is a traditional custom dating back centuries for many Native communities and nations. For non-Indigenous communities, land acknowledgement is a powerful way of showing respect and honoring the Indigenous peoples of the land on which we work and live. Acknowledgement is a simple way of resisting the erasure of Indigenous histories and working towards honoring and inviting the truth. I would like to give a warm welcome to everyone joining us today for the 10th FTAC meeting. I'll start with an overview of the agenda. We're going to begin with roll call as we normally do. This is a great opportunity for us to get to know each other better. So today's icebreaker question is aisle or window and why? So you'll be asked that when we go through the roll call. After the roll call, we're going to vote to approve the May meeting summary, and we'll follow that with public comments. Next, HMA will share where we are in the Commission's 2024 work plan. We'll follow that by a presentation by experts who have experience creating universal healthcare systems in other states, including Vermont and Rhode Island. They will talk about cost-sharing considerations in their universal coverage designs. We'll then take a short break, and when we return, the discussion will continue, and we'll ask for input for questions related to the actuarial assessment that we talked about last meeting. I encourage FTAC members to ask questions and provide feedback to help facilitate today's discussion. I'll turn over to Mandy to go through roll call.
Thank you, David. Please remember when your name is called to let us know the question of the day. And I know Pam McEwen currently had an emergency, and so she's not able to attend at this moment. Hopefully she might be able to join us later today. Christine Eibner.
Here, and definitely aisle, because I don't want to annoy people by getting up and down. I just want to be able to do that whenever I want to.
Me too. David DiGiuseppe.
I'm here, and I prefer aisle, but similar to Christine a lot. I prefer because I have to get up and walk. I can't sit still for a whole flight.
Eddie Rouser.
Present. I would say window because I just like to gaze.
Thank you, Eddie. Esther Lucero. Esther Lucero. Ian Doyle. I did receive a note from Ian that he may not be able to attend today. Kai Young. I also received a note that Kai may not be able to attend today. Robert Murray. Robert Murray. Roger Gantz.
Good afternoon. I'm also a window person. Like to see the great world that we see through our flights.
Thank you, Roger. I will turn it back over to David.
Thank you, Mandy. Please join me in turning to the second tab in your materials. The recording of the last meeting is posted on our webpage. We will use the consensus process for a vote on the approval of the May meeting summary. Is there any discussion of the meeting summary or proposed changes to the meeting summary? All right, hearing none, I propose that the minutes are accepted without change. Any discussion of this proposal? All right. All in favor say aye.
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 Any opposed? All right. We have approved the meeting minutes by consensus. Next, we'll move on to public comment.
Just as a note, David, I think a member, somebody who is identified as Whole Washington has their hand raised. I doubt it's a member. Perhaps they're noting that they'd like to provide public comment, but I just want to allow them a moment to talk in case for some reason somebody was an FTAC member might be dialing on that line or identified that way. So let me just check in real briefly. Hi, you have your hand raised? You're ID'd as Whole Washington?
Can you hear me now?
Yes.
Okay, I'm sorry. Yeah, I would like to change my name because I'm sorry, I'm signed in under Whole Washington's account right now. And I would love to give public comment, if possible. I didn't sign up. I'm sorry, I've just been swamped.
No, that's all right. I'll add you to the public comment list. What's your name?
Catherine Lewandowski.
Catherine Lewandowski.
By now, you probably even know how to spell it.
Well, thank you so much, Catherine. We'll circle back around to you.
Thanks.
Okay, committee members can find written public comments under tab 3. We allow individuals to sign up to provide public comment before the meeting, and we will start with those that have signed up to provide comments. When you're called upon, please state your name and affiliation, if any, before speaking. We will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comment. Mandy, would you please start with the names of individuals who have signed up to provide comment?
Yes, I will. I have Aaron Katz. And Aaron, I will move you over to being a panelist. I see he is still rejoining. Aaron,
Okay,
are you available?
I'm good. Are you?
Yes, good. You are all set. Thank you.
All right. My name's Aaron Katz. I retired from the UW Public Health faculty a few years ago. I'd like to provide some thoughts for your discussion today about cost sharing. During my 40-plus year career in health policy, point of service cost sharing has been an obsession in American policy circles. That's due to a belief that Americans are simply economic animals who, if we don't deter them, make recreational visits to the doctor and hospital. And that, the theory goes, is what drives up spending. That focus is wrong on 2 counts. First, what ails the American healthcare system is not excess demand. A cursory look at international data reveals that for most services, U.S. use rates are lower than in many countries that spend much less on healthcare. Indeed, the seminal paper, 2003 paper, It's the Price is Stupid by Anderson and Reinhardt, showed in no uncertain terms that our problem is the prices we pay for services, not the use of services. Imposing point of service cost sharing is simply punishing people for the sins of the system. Second, we have solid evidence, starting with the Rand health insurance experiment of the late 1970s, that imposing cost burdens is a blunt, often harmful strategy. Cost sharing does reduce near-term use of services, but as Rand and subsequent studies have demonstrated, those barriers reduce access to beneficial services at least as often as they impede use of wasteful services. And this is especially so for lower income people. A 2017 KFF review of the evidence made 2 relevant conclusions. One, even small levels of cost sharing are associated with reduced use of care, including necessary services. And 2, state savings from premiums and cost sharing in Medicaid and CHIP are limited. I urge you to focus your cost containment efforts elsewhere. Thank you.
Thank you. Catherine Lewandowski.
Okay, I'm sorry. Now can you hear me? And I'll start the video. Hopefully that'll work. I'm sorry.
That's okay. Don't worry.
I apologize. Maybe,
No,
okay. Hey, I just want to apologize for not having time to really gather some very cohesive thoughts. We've just been so busy with our Let's Make Healthcare Happen town halls around the state. And one of the things we've learned, we kind of thought we knew it, and we do know it now, that the situation is really dire for many people in our communities, especially in our rural communities. And we just really want everybody to stop wasting time trying to figure out, how to continue this unsustainable healthcare system that we have. Our communities are in trouble. Okay, but in regards to copays, we know, as or the previous speaker said, that adding those cost barriers only inhibit people from seeking the care they need. And then we end up seeing them later in the emergency room when they could have been easily treated in more appropriate settings. They all also seem, we end up feeling like it's just a way for the system to gouge us. For instance, when back in the 1980s, when they became very popular and my insurance company started a $10 copay, had only been a nurse for a few years, but I had lots of issues with dermatitis and such and allergies to a lot of the hand washing things and things. So I had to go to see a dermatologist. That appointment was on a Monday and it was a $10 copay. Oh, yes, you need allergy testing, but we only do that on Tuesdays. And so I have to come back the next day and it's another $10 copay. And then they only read those on Thursday or Friday. So you have to come in and have it read, and that's another $10 copay. So that's $30 in a week back in 1980. Okay. And then now, they want you to be sure that your indigestion is actually a true emergency before you go to the emergency department, or you incur a huge, gigantic copay if it's not an emergency. This is why people are frustrated. All right. Thank you very much.
Thank you. I don't see any other hand raised, but I'll just make a call and see if anybody else would like to make a comment. David, I don't see any other public commenters. I'll turn it back over to you.
Okay, thank you, Manny. Public comments are an important part of this work, and we thank you, Aaron and Catherine, for your comments today. I'd like to welcome back Liz Argent from HMA, who will briefly share where we are in the Commission's 2024 work plan and today's objectives. You can find the work plan under tab 4 of your materials. Liz, please take it from here.
David. Hi, everybody. I loved hearing your answers about the window and the aisle. I just love that there's lots of different kinds of people out there willing to sit in different places on the plane. So that's just wonderful. Fun to hear about that. So I know this is seems repetitive to folks, but just it's important part of our work just to remind everybody about where we've been, where we're going, and how does today fit into that whole conversation, especially because we only meet every other month. And we just need to provide a little context for everybody. So I will go through this relatively quickly. We can go to the next slide, please. So just, I think we shared this with you at 2 meetings ago. We've really tried to get a little bit more granular in the 3 different bodies of work that are happening with the commission, including the work of the FTAC, and really reminding everyone there's one work stream focused on designing the universal healthcare system, and that is really where we have the energy and focus of the FTAC that has come into play over the last year and a half now. And so far to date, we've provided some decisions on eligibility all last year. And our goal in 2024 is to really figure out, the cost of this overall system, factoring in things like benefits and services, cost containment, and provider reimbursement. Just if you can go back one slide real quickly. Also, just the other 2 work streams are number 2 is focused on the interim solutions work. The commission itself has really largely been focused on that. And this year they're looking at administrative simplification and maximizing coverage in existing programs. And then finally, work stream number 3, which FTAC has provided a little bit of support on this last year, is reviewing the Washington Health Trust proposal that has been put forward and looking at it as something to consider alongside the work that we're doing. So that work stream has had that interim report was sent earlier this month to the legislature. And we're now, as we do the work here on benefits and services and cost assumptions, we'll be pulling in information from the Health Trust proposal. Okay, so next slide. And again, just to kind of capture where we're at with work stream number 1, we're really focused on the phase 1 pieces. We spent last year again focused on eligibility, and now we're turning to benefits and services, cost containment, and provider reimbursement eventually, to think about how much this is going to cost, and then start looking at how we want to finance it. So if we can go to the next slide. Yeah, and this is just restating what we saw in slide 1, but really trying to break it out in the sequence in which we're doing the work. So we've been focused so far on benefits and services, but have started wading into the other components, given the interest in trying to come up with an actuarial modeling exercise to figure out how much this is going to cost. We've now realized it's important to start talking about things like cost sharing and cost containment, which we did briefly at our last meeting, and more time today, with the hopes that we can have enough information to provide our actuaries the inputs that they would need to come up with the cost estimates, and then ultimately work with this group to figure out how we want to finance this. So if we can go to the next slide. Just an important reminder that who are we talking about in terms of eligibility? This was the work that was done by this FTAC last year was going through the different populations that are covered by different sources of financing, and trying to sort out where do they fit in this universal system? Is there a pathway to include them? And the decisions that were made last year, all the ones that have green stars, are the populations that we felt like there was the FTAC provided information to the commission suggesting that there was a path forward to include these folks in the universal system and capture the funding associated with them, or the financing sources. However, the folks that are in self-funded ERISA plans and Medicare, the FTAC, deliberated on that and made the practical decision that at this time, there is no pathway to provide coverage to those folks in the universal system and maintain their financing. However, there was a suggestion and recommendation to make sure that those populations have the opportunity to purchase or opt into a supplemental wrap to make sure that their benefits and services look like the benefits and services that the universal population gets. So with that, we'll go to the next slide. So that's really where we got to for this year. So the commission has given direction to FTAC, to all of you, to provide some guidance on developing an actuarial analysis that provides a rough estimate for benefits and services in PEB-SEB, the Uniform Medical Plan, the Essential Health Benefits, Cascade Care Plan, and the Medicaid Dental and Vision. The commission has also given direction to FTAC to provide guidance on the actuarial analysis that shows the cost of eliminating or minimizing enrollees' out-of-pocket costs. And that's really the second group right here, second bullet is really the focus of today's conversation. And so we're fortunate to have a couple of HMA colleagues who have some real expertise in this area to help facilitate that conversation today. And finally, at our last FTAC meeting, David provided information to the FTAC, or a starting point conversation about how carriers set rates, so that we could understand and just really try to engage a little bit more in like the full picture about how costs are established. And then we also got a brief update on the cost containment efforts that are being led by the Healthcare Cost Transparency Board in the state. So turning to today, we're gonna spend our time looking at universal cover systems and cost sharing in those systems, really to get at some of the questions that were brought up during the public comment, and provide some guidance to the actuaries about what kind of inputs that we think make sense for their modeling. And as part of that conversation, we'll be looking at other systems. We'll be looking at the impacts of those cost sharing. And then we'll be looking at the cost sharing that's in place for the selected benefits and services packages that have been discussed by FTAC so far, and then discuss the different options that might be available to provide guidance for the analysis. All right, I'm gonna hand it back over to David.
Thank you, Liz. So next, we will hear from the two experts from HMA that Liz referenced, both of whom have experience with efforts to create universal healthcare systems in other states, notably Vermont and Rhode Island. These two folks are joining us today to present information about cost sharing and universal coverage systems, both internationally and in the United States. Their presentation can be found under tab 5. There will be time after their presentation for Q&A and FTAC discussion. You'll see that we have quite a bit of time allotted with a break during the discussion. We encourage questions and discussion as we go along. I'd like to welcome Anya Rader-Wallach and Hannah Turner. And Anya and Hannah, if I've mispronounced your names, please correct me when you introduce yourselves.
Nope, you got it right. Thank you so much. And I'm going to apologize ahead of time. I had COVID last week, and I still have like a little catch in my throat, so I may need to mute myself in order to clear my throat every once in a while. So I am a window person, just saying. And the reason I'm a window person is I'm a huge fan of John McPhee. And if any of you have read John McPhee's books, he talks about the geography and geology of the US, and I just find it fascinating to think about that from the vantage point of a window in a plane. I am here, my name is Anya Rader-Wallach. I'm a relatively new principal at HMA, and my career, I joined HMA in April, and my career has been mostly in and around state health policy. I'm from Vermont, and as David noted, I was deeply involved in Vermont's effort to implement a single payer system, and the sort of both vision and practicalities of that. So I'll talk about that a little bit later in my presentation. But it was a really interesting experience for me as somebody who would love to see that dream come true in certain respects. It was a real learning experience for me in terms of kind of pricing out what does that mean? How could it work? What are the limitations? You guys have already noted some of them in terms of ERISA and Medicare, and we certainly face that in Vermont. So I'll touch on that later. Dr. Katz, just want to say, I agree with what you said, and I'm a huge fan of Uwe Reinhardt, who actually was a friend. And so I like to I like to cite his deep wisdom whenever I can. So thank you for that. And I'm gonna before I get into the depth of our presentation, I'm gonna toss it to Hannah to introduce herself, and she and I are going to do a two-step here. I'll do some of the slides and she'll do some of the slides. Hannah is much more knowledgeable about sort of the nuts and bolts of the insurance marketplace as it exists, and particularly she's done some research on Washington's insurance marketplace that I think would be helpful to you. So Hannah, you want to introduce yourself?
Sure, thank you. Hi, I'm Hannah Turner. I am a senior consultant at HMA. Prior to my joining HMA, I spent the last decade or so working with state-based marketplaces. So a lot of work on the individual market, working closely with the plans and the plan designs in marketplaces. And then prior to that, my background before that was working as a health insurance broker, mostly with small and mid-sized employers, also the individual market. So I'm pretty familiar with that work. And for the record, I am a window person also, love the view.
Great, thank you. Next slide, please. What we're gonna cover today, and I hope this is, we're sort of dropping in from another planet to your discussion, so I hope that this is on point. But we can take it in other directions if it's not, and we certainly can do follow-up. What we intended to do today was lay the groundwork in terms of some basic understanding of cost sharing and kind of what are the concepts. Most of you probably know that, but we thought it was important that we kind of establish a baseline of knowledge about cost sharing. Secondly, we'll talk a little bit about other countries. I am not an expert necessarily, although I have taught students. I am a professor of the practice at Brown and have done a fair amount of teaching of graduate students at Brown and at Brandeis, which includes teaching on sort of comparative systems across the world. So we'll talk a little bit about that. I think the main point of that, just to give you kind of a preview, is nothing's free. So if you think there are systems in the world where there's no cost sharing, you might be right, but people are paying in a different way. Doesn't mean that they're paying the price that we pay in the US, but they are paying. So we're going to talk a little bit about kind of how do those costs get distributed and how does the cost sharing differ across a few exemplary countries. And then lastly, we'll talk about examples, and this is where Hannah's gonna shine. We're gonna talk about examples from Washington State. So what's out there in your marketplace? What's kind of the what's the status quo? What's the gold standard, whatever you want to call it, what's going on in Washington now. And so as you build a vision for universal coverage, what are some of the examples that you could look to? Next slide, please. Thanks. As I said, we're going to talk about types of cost sharing, impact of cost sharing on total costs, cost sharing's impact on utilization, which was mentioned by a previous speaker, and what are some other sources of financing that you might think about if you want to minimize cost sharing, then what does it mean in terms of other ways that you can cover the total costs of healthcare for a state, for a country, whatever. Hannah, anything you want to add on that slide?
Nope.
Okay, great. Keep rolling then, please. Hannah is now, I think Hannah's going to go through this. This is like the cost sharing 101, and she's going to take you through it. Again, most of you know this, but I think it's useful for those who aren't well versed in it, and as a baseline. So take it away, Hannah.
Thanks, Anya. So common speaking the same language. So deductible is where we have the consumer is going to be paying all of the costs up to for the deductible dollar amount before the health insurance plan starts to pay for those services. It might pay for all of the cost after that. So it might pay for some share of the cost afterwards, but it's basically 100% paid by the consumer up to that certain amount. So sometimes you might make all services subject to the deductible. Sometimes you want to might make certain high, make certain services not subject to the deductible so that you can avoid creating a barrier to care. So often what people look to is like the high value, low cost care. So the most common would be things like preventive care and primary care. So then co-insurance is where the consumer is going to be paying some set percentage of the cost for whatever services they're receiving. So this ensures that the cost sharing between the customer or the consumer and the health plan is proportional to the cost of the services. So if it's a very high cost service like advanced imaging, MRIs, PET scans, things like that, that the proportion that the consumer is paying is the same percentage, but the overall cost goes up as the total cost goes up. The downside to that, of course, is that co-insurance does create some unpredictable costs for consumers. They know going in that there's a certain percentage they're going to have to pay for the service, but they don't always know what that service is going to cost. So it can be really difficult for them to predict what their cost is going to be until after they've used the service. Copays, on the other hand, are a fixed cost for a certain service. You often think of with an office visit, you go to your primary care, you may pay your $10 copay or something. That means that no matter what the actual cost of that service is, you're going to pay the $10 and then the plan pays the difference. So that makes it predictable for consumers, but it does mean that the consumer's cost is not always going to be proportional to the cost of the service. So that can mean sometimes the plan is paying a lot for a service, and sometimes the plan might not be paying a lot for the service, but it's still going to be predictable for the consumer. On top of these different ways you use these tools to create a plan design, you can layer in other things like prior authorization, referrals, step therapy, things to like utilization management tools to avoid high costs, unnecessary high costs. Although it's always a balance, like all of these things, the balance of the cost controls and ensuring that there's still sufficient access to care.
Thank you, Hannah, and you get the gold star for today because I just realized that I told you I would do that slide and yet you picked it up and ran with it. Thank you so much, and you did it beautifully. So those are just examples of sort of mostly in the American healthcare system, how do we try to either shift costs to consumers or influence use of services, utilization of services through higher cost sharing. And as Dr. Katz noted, cost sharing has an impact on the use of services. So this slide gets at the RAND health insurance experiment, which is still the gold standard, even though it was conducted back in the 70s. It established that if people pay more, they use less services. So there's a correlation between the amount of cost sharing that consumers experience and how much services, how many services they use, how much healthcare they use. And this is regardless of income. So at any point on the income scale, cost sharing makes a difference in terms of people's use of services. Kind of fits with economic theory, right? Like it changes your price point. If you would get a service for free, but now there's a $30 copay. If you would get a drug for free, but now there's a $50 copay, it has an influence on how people use services. Growing body of research since then has shown that this has reinforced this research, and most of that since the RAND health insurance survey has been in more sort of specific service areas, service categories, but it all pretty much reinforces the idea that yes, the price consumers face makes a difference in how much they use. A third bullet, small increases can make a difference. And this is much more income sensitive, but copays as small as $1 or $5 can make a difference in how much people use. More and more recently, there's evidence, and this is sort of with the proliferation of high deductible health plans where people are facing potentially really high cost sharing, and therefore their price, their price sensitivity might even be more heightened. more and more evidence that people actually forego what would be considered good use. So, cost sharing has sort of been introduced as a way of inhibiting unnecessary or wasteful use of healthcare. More and more, there's evidence that high cost sharing actually inhibits what we would consider to be good use of healthcare. So preventive services, adherence to drug regimens, things like that that we would want to see actually get impeded by cost sharing. So cost sharing makes a difference. That's the point of all this. Next slide, please. And if anyone wants to ask a question, please just jump in anytime. This is I have to put my glasses on to be able to see this, but this is a representation of sort of the array and distribution of costs in various countries for healthcare. And the point of this is not to get you to focus on any particular country, but to look at, first of all, the lightest blue is out-of-pocket costs. And you can see that most countries, every country on this array has some cost sharing. So there's no place in this analysis where consumers don't face point of purchase cost. But then how you distribute, how much of that gets loaded on the consumer at the point of purchase and how you distribute the rest of the costs, it varies a whole lot in terms of how much is paid through taxation, how much is paid through compulsory programs of health insurance, mostly employer-based programs, but other means as well. And so how much is covered by individuals paying for health insurance out of pocket. So the point of this is just to show you that the distribution changes from country to country, but the same elements are there. And we'll talk in a lot more detail about, and you can see the red column in the middle is kind of an OECD average. But you can see it's all over the map in terms of how the costs get paid. But there's no system in which, at least in this array, in which there's no consumer cost sharing. Next slide, please. Again, the impact of consumer cost sharing on costs, there's advantages and disadvantages. The point of cost sharing is to discourage that unnecessary use, wasteful use, to have so-called skin in the game, as much as I hate that phrase. The only thing I hate more than that is there's more than one way to skin a cat. I'm like, why would anyone want to skin a cat? But anyway, this concept of having consumers think before they use is kind of fundamental to this whole concept of cost sharing. And again, cost sharing can impact utilization either to discourage the utilization of wasteful or low value services. That's increasingly become kind of a nomenclature around this. Or it can be used conversely to encourage the utilization of high value services. So for example, in Medicare, there were some changes under the Affordable Care Act that made it so that there was no cost sharing for some preventive services. An attempt to try to get people to more readily access and use those services that are assumed to be of high value. So either one can be the case. And we'll talk about different forms of cost sharing and examples of cost sharing, but just think of that as sort of an adjunct. I don't think we cover it a whole lot in the slide, but an adjunct to this is what can you exempt from cost sharing in order to encourage good, so-called good utilization. Lower cost sharing. So there's this concept of actuarial value. I suspect most of you are familiar with that, and it's kind of a rough proxy for the balance between cost sharing and shared costs. Shared costs meaning either that which we share because we pay premiums and the risk and actual cost of our services is spread by the premium system, or in other countries, or even in the US under Medicare, that which is spread because it's paid for by taxes. So actuarial value is kind of like the balance between what you pay out of pocket and what you pay. And for those of you who might be tapped, as I am often, to advise friends on how to pick a health insurance plan. Sometimes this is kind of befuddling to them. They think there's some secret, you know, that there's a plan that's actually a better value. And I try to say to my friends who are looking for this kind of guidance, like, you're just making a trade-off. You can pay out of pocket at the point of service, or you can pay in your premium. It's the same cost. You're just spreading it differently. And if you want to predict your use of costs of services, then you may be saving yourself some money if you're really good at predicting that. But basically, you're just shifting it from one category to the other. You're paying more premium, less out of pocket, more out of pocket, less premium. And again, you've seen that sort of get attenuated with high deductible health plans, which are an example of how you take more burden on out of pocket, reduce your premium, but if you end up using services, your out of pocket costs can be quite high. Next slide, please. This is just as we go into comparisons with other countries, wanted to make clear that just because there's a broad source of financing, it doesn't mean that it's kind of fair or equitable. So you can choose to finance that sort of broad-based, non-out-of-pocket expense through taxes, like a lot of countries do. You can choose to fund it through premiums. How you do that makes a difference in terms of kind of who gets hit with the cost. So if you fund it with taxes, in general, in other countries, the costs are spread across a larger population. So we don't have, you guys saw the pie where ERISA gets taken out and Medicare gets taken out, and we're just talking about this smaller slice of the pie. Those taxes can be based on all sorts of things. And I'll talk about Vermont's experience, trying to make it more income sensitive. But you're making a choice in that financing scheme to say, well, what we care about is whether people have the means to pay. So we're going to fund this through a mechanism that is income sensitive. Premiums also spread cost, but it's not necessarily income sensitive at all ranges of the income spectrum. So we've got Medicaid that makes it so that if you're eligible for that program, you have very little out-of-pocket cost. Then we have exchange plans that are on a sliding scale, and then everybody hits a cliff after that. And the costs are not spread based on your ability to pay. So advantages, disadvantages. I won't go through all the details, but you can read this on your own. Next slide, please. This is just sort of more an add-on to what I talked about before, which is there's a clear impact of cost sharing on healthcare use, starting with the RAND health insurance experiment, which demonstrated that, and then research that's come after that. But more and more, there's a demonstrated impact on health outcomes. So high cost sharing can actually impede people's use of what we would consider high value healthcare services, and can actually have a negative impact on people's health, and can actually increase healthcare costs because people avoid what we consider to be high value, what we think to be high value healthcare services, and they end up using services that if they had sought preventive care might not be necessary. The concept around this is there's ambulatory sensitive diagnoses, which is kind of a measure of are people using care inappropriately, using care that if they had access to good preventive care, they wouldn't have to. And there's certainly more and more an association between high cost sharing and the use of services that could be avoided if people had good access to primary care. Next slide, please. So now I'm going to go into some examples from other countries, and then Vermont, which you may think is a foreign country. Again, I'm not a international healthcare comparison expert, but I know just enough to be dangerous. And my main point in touching on these examples is just to show that the overall cost may be lower in other countries, and there's some reasons for that, having to do with price, what they pay, also having to do with cost control mechanisms that they have in place in other countries. Mainly, and I'll talk about this in the Canada example, mainly supply side cost controls. So you can, if you got a pie that is healthcare costs, you can shrink that pie in various ways. It's not easy anywhere. Canada is probably the best example of how they do it through supply side controls. So I'll talk about those, and then I'm going to get into a little bit of my experience from Vermont, because well, we didn't follow through with the single payer plan there. We did a lot of analysis that I think is useful to any state that's looking at these kinds of things. Next slide, please. So this is, again, just an example of, in most countries, consumers face cost sharing. And you can see there's a whole range. This is OECD data. The US surprisingly ends up being, you can see it there, it's like about almost halfway along that spectrum. We appear to not be as to put as much burden on consumers as a lot of countries, which is a little bit counterintuitive, I think, given what people experience in this country. Next slide, please. Germany is a social insurance system, meaning that there's and again I hear Uwe Reinhardt in my head. Social insurance system means like there's a pact that we all have to buy insurance. So it's not mandated in the same way through taxation. It's not a government-run system in the same way that some countries have organized their healthcare system. But there is a system that requires all individuals to have health insurance. Can get kind of complicated in terms of exactly how that works. There's a thing called sickness funds. People get to choose these. And then there's various exemptions, requirements, subsidies. So it's not a terribly simple system, but the bottom line is everybody has to have insurance. There is variation in how people meet their obligation to have coverage. About 10% of the population buys supplementary coverage. And I think this is a really, really, really important thing for you guys to consider as you're thinking about a universal coverage system for Washington is it a system where you guarantee a set of benefits that is a base for everybody and people can buy up from that? Or is it a system where you're guaranteeing what you consider to be an adequate level of coverage and nobody can go beyond that? Or is it somewhere, I mean, there are variations on that theme, but I think that policy question of is this base coverage versus full coverage for the population is really important. And in Germany, you can see that like a lot of the population actually goes beyond what's mandated. There's consumer co-payments and co-insurance in Germany. In terms of what they have to pay out of pocket. Next slide, please. Next example, again, I said this is the example of where there are more cost controls, mostly on the supply side. But Canada is basically a government-run health insurance system. So there's a defined benefit package for the entire population. It's all funded through taxes. There's very little consumer cost sharing. There's no allowance for buying up from the government system. And as a result, it's an expensive system. Like ours, it's an expensive system. And so cost control is really important in terms of keeping what is basically a tax-funded system from running out of control. And like all countries, this is a challenge for Canada. As I've said a couple of times, cost control in Canada is mostly achieved through supply constraints, meaning there's limits on the availability of technology, there's reduced choice of provider, there's wait times, all of this stuff that you hear kind of negatively thrown at the Canadian healthcare system. But that is how they try to keep the total cost of the pie under control. Next slide. Last example I'm going to give is France. I'm less familiar with this than the other two, but I think it's an example of a more mixed system where you have sort of a base amount of coverage, and people can buy up from that, and there's a lot more variety about how people sort of at the end of the day end up getting covered and how much cost sharing they face, but still within that social insurance framework where everybody's expected to have coverage. And the last bullet, again, I just want to emphasize that, thinking about like, what's the policy around cost sharing? There's the, what do we want to inhibit through cost sharing? But there's also what do we want to encourage? And so France is an example of a place where a lot of sort of desirable use is encouraged by exempting services from cost sharing. Next slide, please. Now I'm rattling on. I want to make sure I give people a chance to ask me questions before I just continue. Yeah, Christine.
Hi. Yeah, so I wanted to ask about the evidence on, you mentioned there's a growing body of evidence that shows that cost sharing is associated with adverse outcomes. I wanted to ask whether, do you know whether that literature is really focused on high deductible plans, and is that what's causing that those worse outcomes, or are we talking about run of the mill, like, early version of cost sharing where you're talking about $30 copays here and there? Or do you know the answer to that?
I'd have to look back to see how much that's differentiated in the literature, but I know a lot of it is focused on adherence to drug regimens, and that folks are much less likely to buy the drugs, stay with the drug regimen if they have higher cost sharing. And if I recall correctly, I don't think that's just specific to high deductible health plans, because as you know, like a lot of insurers now have stepped step therapy and various levels of co-payments based on the expense of the drug, cost of the drug. So I don't think it's just about high deductible plans, but I have to go back and look.
Thank you.
You're welcome. Roger.
Yes, thank you. I was just about to say the same thing, if I might. And Christine, I think my continued review of the cost sharing literature, as we all know, the gold standard still remains the work that your organization did, the RAND studies in the 1980s, and the basis for that for subsequent analysis. My point would be is in those studies, the cost sharing designs were not around high deductible plans. So to your point of saying, well, we've seen these adverse effects, which might be because of the high deductible plan phenomena. I would say most of the literature, again, using the RAND study as a linkage to that, would be no, it exists otherwise. And if I might interject, I think, quite frankly, Aaron hit in his early comments really hit on the mark on these aspects. I'm kind of, my thing on here is that my take has always been that cost sharing works. It does have an impact on utilization, but I think it also proves in what Emre was saying is that unlike maybe other markets, in the healthcare arena, in my opinion, we are not really good cost-conscious consumers. By that I mean is cost sharing can impact utilization, but unfortunately it can do for essential services, primary care and others that we've talked about, and conversely those that might be viewed as more elective. And our ability to discriminate in general is not very good. So as I think others have pointed out, it's at best a blunt instrument.
Right. In a market that's like very dysfunctional, right?
Mm-hmm.
Like the idea that we even know the price we face is kind of sketchy at best, right? And that's partly just about how sort of obfuscated healthcare financing is in this country, but also it's about how consumers of healthcare are not like we're not buying cars. We're not looking at consumer reports. We're actually going into an office with somebody who probably tells us what they think we should do and we take their advice. And we have no idea what the price is. They probably have no idea what the price is, right? So it's a very weird market. Eddie.
Yeah, that was a good, the 10% number's kind of been thrown around. With your research that you've done, looking at other countries, is it the price is lower because the overall industry in that country, it has a better supply, a better control of costs? I mean, what is on that spectrum? We seem to be on the high side, where we're looking at a menu we don't know the price of, and in other countries, do they have a better control of that menu, and so the customer can see? So there's more choice, drive down the cost.
Yeah. Yeah, I would say, and I'm gonna go into gross generalization here. Warning. I think in my limited research, I haven't seen a lot of systems where the consumer is really very aware of the cost of healthcare. So I think you have kind of two extremes. One is our system, where a lot of the load of costs, more and more of the load of cost gets loaded on the consumer. And they're kind of vaguely aware of what drives that and how their individual choices can have an influence on that. Mostly just having to do with, do I go buy this drug? Do I go seek this service? At the other end of the spectrum is kind of a more paternalistic system where nobody is really expected to know. And Canada may be the best example of that, where it's sort of nobody's expected to know. The UK is probably like this as well. What healthcare costs, except that they're paying it in taxes. And so there's a certain amount of transparency associated with that, right? And this is kind of, I'll get into the Vermont example in a minute. Part of what we were trying to do is just make transparent what is so not transparent now. And we put it on the tax rolls and people become aware of it in a different way. But that's more about what's the overall burden of this social insurance system. It's not so much about what's the cost of the service I'm seeking right now. And so the cost control comes in with government deciding, well, we're going to put a brake on the availability of certain drugs, or we're going to negotiate better prices, something we don't do in this country, for drugs, or we're going to put a brake on technology. You can't get access easily to certain things. So it becomes more of a, sort of command and control. And the consumer awareness is more around what's the tax bill and the whole thing.
In your experience, is there one country that has hands down the best supply figured out, or is it for healthcare for that country? Like they just have done it right?
I'm sorry, I think I missed something. Which country is that?
No, is there like a good example?
You're asking me, sorry. I thought you had the, yeah, I thought you had
I
the answer.
wish.
It's all trade-offs.
Yeah.
I call myself a fundamentalist agnostic. And when it comes to health policy, that is totally true. Like the more I learn, the more I know, the less I know what the answer is. It's just trade-offs, right?
Yeah.
Like, how do you want to fund it? I do favor a system that's more transparent. Ours is convoluted and hard to understand. And therefore, the market signals that we're giving people are really, really, really diluted. And I think that's true on the consumer end in the US and also on the provider end. Like we try to create all these new incentives for providers and they're so diluted that it doesn't really work. And that's
Yeah.
probably another day's business. But Roger.
Yeah, can I respond to Eddie's question a minute? Let me try one of that because I think when you we're talking about Canada and one of their strategies of controlling the supply side, it's for hip replacement. Well, we hear this, continuing in the States, you got to wait 6 months, you're in the queue, you get tired, you come to the US, those sort. And I'm sure some of that's true. What I think a general observation of the US system, I'm trying to go back to Eddie's about supply. If you're looking at supply in the context of especially high-end tech, specialty services, and other things like cancer interventions, heart, etc., I would suggest that per capita, the United States has among the highest of those services per capita supply, number of physicians who perform those endeavors. Conversely, one of the crises we hear often in our country, and I think this is also true, is in the area of primary care, where we look at the number of family practice doctors, interns, et cetera, who provide primary care. I would make a suggestion that our per capita number in that respect is low relative to certainly among the more industrialized countries. So it's not, I guess what I'm trying to say here is I'm not sure we can judge the effectiveness of a system, unfortunately, by how we when we just look at the supply capacity of the system. Other than the argument can be made, if it's out there and the supply is there, it will be used.
Right, and that's a value. There's a value choice there, right? Like there are systems that cap their total cost. It's all tax funded, and they may shift the resources to primary care. They may shift them to lower cost providers in order to be able to spread the money more. But those are resource allocation issues and decisions that other countries make, regardless of how they're financing the whole system. Again, if you're funding it all through taxes and you have some sort of command and control, then those decisions are more explicit. They're not so explicit in our system.
Anya, I just want to do a time check. It's about 3:10. I think we have maybe 45 minutes allocated for the discussion. I think you probably have about 20 slides. So maybe we could go through the Vermont section and then stop there. Kind of questions.
Yeah, I'll go really quickly and hand it over to Hannah. I just wanted to bring, because it's a state in the US and we went through this example, about 14 years ago, Peter Shumlin became governor in Vermont, and he had run on a campaign platform of trying to implement a single payer system. I live in Rhode Island, and I moved back up to Vermont, which is my home state, to help him figure out what the heck was he talking about and how could he make this happen. Everybody talked about Medicare for all. I'd say the first thing to note is I don't know anybody who wants Medicare for all. Even though we talk about it, even though my then Senator Bernie Sanders talks about it, Medicare is not great coverage. There's a lot of gaps in it, and the cost sharing is very high. And so when you get right down to it, nobody wants Medicare for all. People actually want Medicaid for all. But they don't want to do that with Medicaid payment rates. And so then you start talking about like, what can you actually do? In Vermont, we had a significant political influence from the teachers union and also from the state employees union saying, if it's not our coverage, we won't support it. Their coverage was very expansive, not Medicaid in the sense that it didn't cover long-term services and supports, but very comprehensive coverage. We priced that out, and that was a gazillion dollars. It was a very expensive thing to bring everybody in the state up to the level that the teachers union was at. Was really, really expensive. So then we looked at, is there something we could do? And again, this gets back to that policy decision, fundamental. Is this base coverage or is it coverage for everybody? And so we started looking at scenarios where we scaled it back and said, well, this is base coverage and some people can buy up. And then, constituents started to, our coalition started to fracture around, well, no, we don't want different levels of coverage for different people. And on the cost sharing front, people didn't want to have high cost sharing. But again, if the burden is not borne through cost sharing, then it's borne through premiums or taxes. In this case, we were talking about tax funded systems. So the price just kept getting bigger and bigger and bigger. And particularly in a state where you can't, you have no control over ERISA and you're really restricted in terms of financing mechanisms as a result. The availability of revenue streams, and particularly revenue streams that keep up with healthcare cost growth, was basically nothing. And so the governor came to a decision that he could not go to the legislature and the voters with a plan that would fund that kind of coverage for all Vermonters on the kind of revenue sources that were available to us. And even though he made an attempt to create a cost containment system in the state, and I was actually the first chair of called the Green Mountain Care Board, which is the healthcare cost control board in Vermont. And he felt like that was important in terms of making sure that costs didn't outpace the growth in the revenue stream. The expectation that a state on its own can have a different rate of cost growth than the rest of the country is kind of unrealistic, and that has played out over the last 14 years. You can try. You can do supply side stuff, you can do demand side stuff, but one tiny little state on its own isn't really going to be able to buck the trend of what's happening in the U.S. healthcare market. So I hope that wasn't too depressing. That was okay. Now it's going to go to Hannah. Do you want to take David, do you want to take a break before we go to Hannah to talk about the local examples?
No, I think we're okay, Anya. Thanks for asking. We have a break scheduled right after this presentation.
All right, great. Hannah, you want to take it away?
Great. Thanks, Anya.
Yeah.
You can go ahead and go to the next slide. So in this last section, what we wanted to go over with you are sort of a deep dive into different cost sharing examples that apply to folks in Washington State. So you can kind of see different approaches that are used to design cost sharing across a range of these programs. There's a lot of information in here, so I'm mostly going to be focusing on sort of highlighting and so we can compare them and compare different approaches to each. And but there's a lot of detail in here, including more in the appendix for those of you on the committee. So we're going to start with Medicare because, as Anya mentioned, one thing that always comes up with universal healthcare is, let's talk about Medicare for all. I think there's a lot of misunderstandings about what Medicare actually looks like. So go ahead and go next slide. Right. So generally, Medicare eligibility, that's going to be for folks generally over age 65. There's eligibility for special populations, so disabled individuals and individuals in certain diseases like end-stage renal care, for example. And the structure of Medicare is the different parts of Part A, hospital coverage, Part B, provider coverage, Part D is your prescription coverage. And then those three, you can have an optional Medigap plan on top of that. That's what I'm going to refer to as sort of traditional or original Medicare. It's not really all original because they came in different. Part D came a lot later, but that's what we're going to refer to. And then we'll just briefly touch on Medicare Advantage as sort of an alternative to that original Medicare group. And of course, as discussed, I think mentioned earlier, Medicare is obviously funded through employment taxes. It's split roughly half and half with the employer and employee. That changed a little bit with the ACA. But going to the next slide, and we'll talk about the premium structure for Medicare. So these are, again, sort of the traditional or original Medicare. Part A, the hospital coverage, that's generally free for the vast majority of individuals, that as long as they've timely enrolled. And in fact, across the board, you'll see Medicare premiums are going to be based on timely enrollment, and there's almost always a penalty for if you don't enroll when you were originally eligible and should have enrolled. So we're the top level of premiums they're looking at here is going to be for those timely enrollees. The only time apart you're going to pay premiums for Part A is for individuals who haven't paid into the Medicare premiums, taxes for basically 10 years. In that case, the current premiums, these are 2024 premiums, are $278 or $505 per month. The A premiums, if you do have a premium and you're lower income, you can have that premium reduced. And actually kind of across the board for most of Medicare, if you are lower income, the premiums can be reduced. But note, it's not just lower income, it's actually lower income and limited resources. That's a little bit different than some other programs that will reduce premiums for lower income individuals that don't necessarily look at the resources. They might just look at income. Part B premiums, that's for Part B is your provider and like outpatient services. 2024 rates, it's $175 approximately. Obviously, it can be reduced if you're lower income, but interestingly, Part B and D premiums can go up for the higher income individuals. That was one thing that changed more recently. So it's not only lowering it for lower income, it's also making higher income folks pay a little bit more as well. Part D premiums are, Part D is like a bunch of different plan designs. So the premiums are going to vary by plan, but I did find for Washington State, your 2024 average premium for Part D is $42 a month. And again, there can be reductions and increases in premiums based on your income. And then for Medigap, premiums can be all over the place, and there's a lot of different plan designs. So wasn't really going to quote you any premiums there, but we'll go to the next slide and talk just a little bit about sort of the benefit structures here and how they play together. So first thing is the hospital coverage, the Part A. Big initial deductible, that's $1,600 deductible for when you go in the hospital. And then you don't have any more cost. You start to get a per day cost after you've been there for a long time. So after 60 days, you get a per day cost. Slightly similar model, but slightly different cost sharing for some of the other facilities like skilled nursing. Hospice is a little bit different structure as well, but the same idea of an initial, you start to incur some per day costs eventually. But I think that initial hospital deductible on A, something people don't always think about. For Part B, it's that's the provider and outpatient, simple structure of a deductible that applies to everything, and then a 20% coinsurance across the board. The only thing that kind of is different is that, the recent change that now there's some certain preventive services for free, but in some ways it's a nice, very simple model of just deductible and then coinsurance no matter what type of service it is. Okay. Part D is incredibly confusing. I did my best to try to show this. I'm not going to go and try to do a Part D seminar here, but I think the key things about the way the standard Part D plan is designed that is interesting, of course, is there is a separate deductible that's just going to be for your prescription drugs. And then you're paying a coinsurance up to a certain point, and there's an out-of-pocket maximum. And actually, starting in 24, there's no coinsurance for someone once they get to the catastrophic level of coverage. Previous iterations of Part D did have some coinsurance above that. One thing I find very interesting about Part D design is that out-of-pocket maximum is not a traditional out-of-pocket maximum. It's because when you look at a plan design for out-of-pocket maximum, it's usually the cost that the consumer pays like everything they paid for. It might be deductible, it might be co-pays, co-insurance. You just keep adding that up. And once you hit that number, then the consumer doesn't pay anything else for any services. For Part D, it's not just what the consumer has paid. They also get to count the manufacturer's discounts for drugs during the coverage gap. And that's, so during the coverage gap, the standard plan pays, you pay 25%. The manufacturers, I think there's like 70% now. So you get to actually count the discounts from the manufacturers towards your out-of-pocket maximum. It's an interesting way to have an out-of-pocket maximum and maybe make it a little more achievable by including some other costs in there. You see the tier breakdown of drugs. This is the nationwide median. Hard to find medians by state here, but I think the key thing is tier drugs with your cheapest drugs having relatively low costs, these fixed copays, $0 or $5. And then for your more expensive brand, non-preferred and specialty drugs, percentages. And over time, we have seen those higher tier costs for sharing. It's been increasing. So it's getting more expensive for consumers to have those higher tier drug costs, drugs, but the lower cost drug cost sharing has generally been going down. You're getting that staying controlled, but that's a way of the plans controlling costs. The Medigap is a supplemental plan that is optional. You don't have to buy that, but it does kind of reduce your cost sharing on parts A and B. So it reminds me of the Germany program that Anya was talking about, where people buy supplemental program plans. It's a bunch of different plan designs, but it will reduce the cost sharing. For example, most of the GAP plans will reduce the inpatient initial deductible down to 0, for example. And there's a few things where they can add some additional benefits into. I think the most popular one is the foreign travel emergency care. Not a ton of options for things they can add in there, but there are some additional benefits that they can add as well. So that's a way of sort of the idea of having this core plan where people can buy up with some different designs and paying a little bit more based on what they, these like supplemental plans.
And Roger has a question.
Yeah, I was just gonna bust it and say, Roger, I have a question. Thank you.
Roger, you're on mute.
Thank you. Sorry. Hannah, could you clarify for me again on the Medigap policy, just to reconfirm, Medigap covers cost sharing, point of service cost sharing for Part A and Part B, but does not for Part D. Is that accurate?
Correct. Yeah.
Thank you.
And just, I just want to take a moment to like step back and think about this conceptually. This is our social insurance program, right? This is what we guarantee to people over 65. And what's represented on this slide is how we control the cost of it.
Mm-hmm.
Aside from like rate cuts to providers and all the other things that happen in Congress to keep the cost of the program under control, this is what we do in this country to keep our social insurance for a limited array of our population under control.
Great. Going to the next slide. So to sort of summarize what I wanted to do for each of these types of programs was to give you a good summary at the end, and then we can do some comparisons of all of these at the end. So sort of a traditional spreadsheet of benefits, the core benefits model over here, which is just reflecting what we talked about, that there's that initial deductible for Part D, and then almost everything. It's a very simple co-insurance after the deductible applies kind of regardless of services, preventive being a recent exception now. Most services are subject to the deductible. So that's sort of this column on the end here. Premiums vary by income and the timely enrollment, with that lower income folks with lower limited resources can get lower premiums, and then higher income individuals paying higher amounts. That's sort of unique in Medicare compared to some of the other programs that we're going to look at. The prescription drug variation makes it a little bit hard to compare, but in general, you're looking also at these separate prescription drug deductibles. Often, some plans don't have one, but a lot of them do, and the separate prescription drug out-of-pocket max. That's not the same across all of these different plans that we're going to be looking at. And then this optional buy-up of the reducing your cost sharing by purchasing the Medigap plan. And those designs vary. Sometimes it just reduces, it gets rid of your Part D B deductible, or it might reduce your cost sharing for certain services, the 20% down to 10 or 0 for certain services. So let's go to the next slide, and we will briefly just explain Part Medicare Advantage, the Part C, which is sort of an alternative to your traditional Medicare structure that we just talked about, where it's private insurance plans that anybody's eligible for Medicare can generally enroll in an Advantage plan. And think of the Advantage plan as a private plan that replaces this very strict Medicare traditional structure. You're going to have that instead of what we just talked about. There may be additional premiums for that, but the advantage, pardon the pun, is that the plan that you're going to buy can have a lot of different variations. They could have a ton of different additional benefits. There's a lot of encouraging of the insurers to create some, to be creative in their plan signs, because to Medicare, to the program, the costs are somewhat fixed, regardless of how someone utilizes services. So the incentive is on the insurers to design the plans to control costs, and that's how they don't lose money. They can offer additional benefits. They can actually even pay for your Part A and B premiums. So not only would you maybe not have to pay premiums for an Advantage plan, you might not even have to pay a Part B premium either. So it's a model of saying, instead of this core program, here's you're going to buy into this other type of program that where the insurer is incentivized to kind of control costs, and consumers can pick from different designs that they would fit their needs. So there's so many different Advantage plans. We're not going to compare the details, but it's important to know that that is out there as an alternative to your traditional or original Medicare.
And I don't want to complicate things, but I just want to add in that an important, maybe critical factor in terms of Part C is the rate at which plans get paid. So sometimes plans have gotten paid quite handsomely, and therefore it's desirable for them to be in this. And they have flexibility to offer lots of things, and sometimes that has not been the case. But that federal pricing of the payments to Part C plans has been a really important variable in this.
Okay. So now let's move away from Medicare and talk about the ACA marketplace plans. In particular, we're going to talk about the Cascade plan, care plans here. Excuse me. Go to the next slide. So this is for Washington residents who are eligible for the individual marketplace and private insurance plans. They're going to cover all of your ACA essential health benefits, but this is a standardized plan design. And the overall design is going to be very different than sort of some of the overall designs of Medicare. Your Cascade Care plans are going to emphasize lower deductibles and providing access to a lot of services before someone has to pay the deductible. And of course, they can only get those through the Washington Health Plan Finder. In terms of premiums, there is no precise set premium because it's going to vary by the different plans, by your rating, by your geographic area within the state, and by age. But you can be eligible potentially for tax credits through both APTC and then the Cascade Care Savings. That's going to reduce your premiums for lower income individuals. And here we're talking about just based off of your income. There's no resource or asset tests here like there are can be for Medicare. And then not only can your premiums get reduced, but you can actually get reduced cost sharing as well for the lower income end of folks as well. Potential for some surcharges for tobacco users, which comes into play in a couple other places as well. So let's go to the next slide and let's look at what those plan designs look at like in the same kind of standard structure that we talked about for Medicare. I will note here on this slide, just to keep it simple, we're only looking at the Cascade Care plans that are at least an 80% actuarial value or higher. There's like a silver plan that's 70% and a bronze plan that's 60%. Pull those out. They are available in the appendix, but this is trying to keep more apples to apples across the different plans that we're looking at, and that's sort of my understanding. So we're looking towards what the commission is looking for is sort of these, at least sort of an 80% type of actuarial value plan. So if you look at these plan designs for the gold plan or the 2 silver cost sharing reduction plans, which are available for folks who make either less than 200% of federal poverty level or even a little bit lower, you'll see the design, though, I think is what's really interesting. So the single asterisk on any of these benefits means that it's subject to the deductible. And you'll see in general, the only things that are going to be subject to deductible are emergency room, advanced imaging, and maybe your outpatient surgery and inpatient. So those highest cost items are where your deductible applies, but virtually everything else is copays versus coinsurance. So that predictable flat dollar amount, fixed dollar amount for the service, and without the deductible applying. So trying, designed to keep barriers to care down. One other thing that I'll note that is you'll see a trend with these where urgent care is going to be a lower cost sharing than an emergency room. And that's something you see with this plan, you'll see with some of the other plans. That whereas Medicare took this very simple design of saying, let's just apply the same percentage on the marketplace plans, you're seeing an acknowledgement that urgent care is generally a lower cost and high value benefit compared to emergency room for things that are not true emergencies. So if someone could go to urgent care, this style of plan design is to say it's a lot easier to go and have a fixed copay than wait a long time in an ER and pay a lot more money. And so you're using the design to encourage utilization of the lower cost, higher value services and avoid those very high cost services like you get in an ER when someone doesn't need the ER.
I see Roger has his hand up again.
Yeah, thank you. Maybe this is a question for Pam. Pam, very briefly, I'm familiar with Cascade and the Cascade bronze, silver, and gold. What's the difference between the 2 silver plans? What do you essentially just have 2 silver plans?
Pam is not here, Roger, but Mandy or I also
Sure.
see Jane's in the audience, but I'm wondering, Mandy, if you can answer that question.
Yeah, and just really quickly, Liz, I am here. I just
Awesome.
joined, but I'm not sure I can answer Roger's question as to why there are 2 silver plans, and I don't think we have anyone from the exchange. So Mandy may be our best bet.
But the difference between them, I think it's what we've been trying to illustrate. Like if you look at 94% AV versus 87% AV, it's just a matter of how you distribute the cost between cost sharing and premium.
Sure, okay.
That may be too simple, but okay. I'll ask Hannah to do color commentary on it.
Thank you.
I apologize. I don't think I explained it well. Unfortunately, I sometimes slip into marketplace acronyms and forget to step back and talk about them. So silver plan, the marketplace plans are generally bronze, silver, gold, and platinum. Mm-hmm. Remember those cost sharing reductions I talked about for the lowest group of lower income individuals? That is available on top for these cost sharing for the silver plans only. So you can buy a silver plan, you're going to pay a silver plan premium, but you're going to get a benefit that's a much higher actuarial value. So there's actually 4 different versions of a silver plan. There's a normal 70% silver plan actuarial value. Then there's a 73% cost sharing reduction, where usually you'll see like a little bit of a lower deductible. And then the next level for the next kind of lower income level is going to be this 87%, where you see even further reductions in deductible, copays, and then all the way down to the 94%. So the 94%, that's for folks who are at 150% of the federal poverty level or lower. So that's like an individual making around $22,000 or a family of 4 making roughly 46,000. And then the 87%, that's going to be folks making up to a single person making 30,000, or I think it's around 62,000 for a family of 4.
Thank you.
How simple is that?
Yeah, yeah. So you show me just very briefly, these are variances due to the cost sharing subsidies that are available through the ACA. And when you imply those with these various income bands, this is what the actual aspect of that looks like. Thank you. Got it. Got it. Thank you. Thank you. Thank you.
Yep. And if you go to the marketplace and you say, I make $200,000, you're never going to see these 2 silver plans. You're going to see the 70% plan. And no matter what, if I make the $200,000 and I see the 70% plan, and Anya makes the, whatever I said, 20,000, that gives her the 94%, we're going to pay the same premiums. She just gets a lot less cost sharing for using services.
Gotcha. Thank you.
Hannah, just one more time check. We're at 3:38 on my clock. If you could aim to wrap up the slide piece at 3:45, so we have a few minutes of discussion that might help us frame up the information that we'll use in our subsequent discussion with Millen, that'd be great.
Yep, I can do that. I'm going to go right on to the next slide.
Thank you.
On the PBBs. And these are your private insurance plans. They're interest, actually, why don't you skip this and we'll go to the next, and I'll just talk about, these are for your public employee benefits. Again, I have a summary of your different plans. Here, the sort of, apologies, they're small because there's just a lot of plans, but the last 3 blue columns are those uniform medical plan, PPOs. You'll see the plan design here are going to be actually a lot more like Medicare. There's going to be a deductible, though these are relatively low deductible for most services. And then generally it's like a 15% co-insurance for kind of across the board. It's a simplified plan design for that uniform medical plan. Whereas in Medicare Part D, remember, it's like a 20%, but the same idea, a relatively low deductible for services and then co-insurance for almost everything. Even the prescription drug plans are kind of similar. There's a deductible and then different cost sharing with like really lower cost sharing for the lowest, they call them the value level. It's like, the most high value, low cost prescription drugs, and then it can go up from there. But again, almost every service is going to be subject to deductible. And the only thing they do a little bit here of a similar design of encouraging urgent care over ER by saying it's still the same co-insurance, but you notice there's an additional copay if you go to the ER. Again, trying to discourage people to go to the ER if they could get the benefit, get the service at an urgent care. So the other thing just to point out here, and I do have the premiums listed because this is an employer-sponsored plan, the premiums don't vary by age, they don't vary by your income. It's a fixed based on the number of family members that are enrolling. Although I do believe there might be some tobacco supplements, surcharges that could also be applied, just like on the marketplace, although there's no tobacco surcharges on Medicare. So the trends, again, co-insurance for most services, most are subject to deductible, and then these separate prescription drugs, and actually a separate prescription drug out of pocket as well. Okay. Next slide, very briefly, Medicaid, as we talked about, it's just going to be for your lower income individuals and some additional populations like pregnant individuals, children, and other populations. Most importantly is you can get it a managed care or fee for service, but you're not going to pay premiums, and your services are basically covered with no cost sharing. There are other ways they do some utilization management, like there might be prior authorization, referrals for certain services, since there's really no control from a cost sharing perspective of discouraging people from using services that are high cost. So there are some utilization management tools that are built in some of the Medicaid programs. But only wanted to show that because I want to get to the last slide after this, which is what I think is hopefully a helpful tool for you. You can go to the next slide, is a way to look at these 4 different types of plans, the trends between them sort of side by side. So you'll see like the cascade care plans. I took all the ones that we showed and sort of averaged across them what these co-pays you might see for that service. If there is co-insurance, what the average of that is, and then how often the deductible applies. So again, you see that trend of copay for almost all these services without without a deductible applying versus the PBP, and Medicare definitely heavy on the co-insurance and deductible applying to many of these services, with of course the Medicaid with no cost sharing. So the trends here, the premium, sometimes there's lower cost premiums for lower income individuals, with Medicare having that weird asset test as well. And the age rating on the Cascade Care can be a little different, and then the tobacco rating can apply to Cascade Care and the public employee plans. And then just some of these cost sharing trends like I just kind of went through with these so that you can kind of see what these look like side by side and how they take different approaches to the plan design with different goals in mind for different populations, right? For different reasons. So I think
Thank you, Hannah. You're awesome.
but it's long, but
Yeah.
they're
And you know, I think like for a lot of people, that last column, like look at that in that nirvana. Except that what we do in that program is pay less. Our prices are lower, right? You know, it back to the original comment, like it's the price is stupid. Like, yeah, the reason we can do that in Medicaid is because we pay less. And then we do all these kind of machinations in these other programs to not pay less, but control use. So there's your choice, but they're not easy. And I think now we're going to take a break and come back and talk about it.
Yeah, well, Hannah and Anya, thank you very much. You know, Hannah, all this comprehensive information you went through is a great setup for and reference tool for the conversation that UHCC has asked us to have and advise on. And Anya, I'm fascinated by your experience in Vermont. It sounds like 14 years ago you were having the conversation that we're having today.
Yeah. And it ain't easy. It's like, yeah, cost is cost. And how do you want to make the pie bigger or smaller? How do you want to split the pie?
Yeah.
Not rocket science.
Yeah, I think your points about the interdependencies of cost sharing, premium, and taxation are critical for us all to be thinking about, because ultimately, as we think about a unified system, we quickly pull in discussions around tax policy and equitability across the entire state.
Right.
I do have one question for you. When you had mentioned that Medicare is a less than ideal design, my understanding is that the actuarial value of the cost sharing in original Medicare is about 23%, meaning the cost burden, about 23% of the cost burden is on the beneficiary, which, if that is true, that's in between the actuarial value of a silver plan and a gold plan on the exchange. Is that what you meant, that even 20 to 25 to 30% is too much burden on a consumer and an ideal system would be less than that?
So I don't want to opine on an ideal system, but I would say that I think some people who advocate for a universal system would find an actuarial value of 80-something% to be inadequate.
Got it. Okay.
I think others would say, yeah, that's okay. And again, look at the international examples and you can see there are countries where that's considered acceptable, right? We guarantee a base amount of coverage and you want more, buy more. Or yeah, I mean,
Yeah,
that's
I understand.
kind of the bottom line. And then there are systems where people say, no, everybody has to have the same thing. And then you have to have some command and control and cost containment in order to make it possible for everybody to have the same thing.
Got it. Pam, I see your hand up.
Yeah, and I like having the shoe on the other foot and being able to ask questions. Um, so one of the things that is you didn't mention, and I came in late, so I might have missed it, but and this doesn't really apply to cost sharing, it's to premiums. But I know that the original thinking in the Affordable Care Act is that the premiums would be set kind of by level of income, that you wouldn't have to pay higher than a certain percentage. And I think it was 10%. And I think it was actually improved under ARPA to 8%.
8.5, yeah.
Yeah. But I think that's an important principle too, especially in our system where people do have such a heavy burden of cost sharing. I think where we have gotten out of control somewhat is that people may be protected on the premium, but they're not being protected on the cost sharing.
Yeah, and I think, editorializing, but I think a fundamental weakness in our system is nobody knows what they're protected from. Right? Like, it's so fakakta that that nobody knows like what applies to me. How do I buy the right thing? It's just yeah. End of editorial comment.
Pam, if I can add on to what you were talking about, you're right. I think the ACA did design so that the tax credits are designed to say that you should never pay more than a certain percentage of your income for premiums. But I will note a couple of different, and it is better. It's 8.5 is the max for someone who makes 400% of the federal poverty level. But those folks who make that, who would be eligible for that CSR 94% plan, that rich silver plan, they can actually get a plan for $0 premium. It gets that low now under the enhanced subsidies. But that cost sharing, so that 8.5% for someone who might make $100,000, that is based off of a silver 70% actuarial value plan. So it's not based off of those plans, that's higher levels of plan designs that we were talking about. So sometimes you can find people who feel like even at 8.5% of their income to pay for a 70% actuarial value plan, it still can feel sometimes like there's still a lot out of pocket that they are still having to owe. But the structure, you're right, was very unique in setting it up to control your cost to your income and not based on what the cost of the premiums were.
That was my point, which is that the protection isn't worth very much if it doesn't help with these, if you're paying more out of pocket. Yeah.
Gary?
Oh, sorry.
Thanks. That I think that's a really key point in the design of the ACA. So you're protected against paying premium, but then you have a $6,000 or $7,000 deductible, which most people will never hit. So if they're reasonably healthy, so what you're actually buying nowadays is really looks more like a catastrophic plan than it looks like a healthcare plan. Now you do get some services pre-deductible, so you get your preventive care. And then the other thing is people who are not eligible for a subsidy don't get that premium protection, right? So they're paying more. And this was a cause of a lot of unhappiness in 2023, 2024, when people found that they were having to pay more than they had been paying before, particularly if they were young men, because they had lost the advantage that they were having before the ACA of being male, because being a woman was treated as a pre-existing condition, and their age, the advantage that they got for being young was reduced because the amount that you could charge older people more was cut back by the ACA. So there were a lot of impacts of the design of the ACA because it wasn't really looking at total cost of healthcare for a person. It was really focused, as we've been discussing, on premium.
Yes, and just to note, as a former Medicaid director, that we also took a lot of those males onto Medicaid because that was part of the ACA. Good policy from my perspective, but
All right, well, that was a fantastic presentation, great discussion. Are there any more questions from FTAG members? Just keeping in mind, starting at 4 o'clock, we're going to be talking with Milliman about some of the assumptions we want them to incorporate in their actuarial assessment of some of these benefit design cost issues. So this is a good chance to ask any final questions that might help think about that next discussion.
and I hope this was responsive. We kind of jumped in without having a whole lot of context. So if there are questions you want to follow up with, please send them our way, and we're happy to engage with you further in the future.
That's great. Thank you very much, Anya and Hannah. We appreciate it.
You.
We're going to take a break. I think we'll just stick with the original timing and reconvene at 4 o'clock. See you in a few minutes.
Audrey, would you be able to put up the break slide?
Yes, I was just working on moving that over.
Thank you so much. I figured you were, but I just wanted to double check. Thank you.
Absolutely.
David, a nice job of ushering through the meeting so far.
Oh, thanks, Roger.
Good job.
I know you mentioned movies before. Have you seen any noteworthy movies since the last meeting?
No, but something that I'll be brief on this. Wes Anderson has a series of short movies. I'm forgetting the author's name just a moment. They're really great and they're on Netflix. So look, Wes Anderson, Netflix shorts.
All right, good tip. Mandy, I think the icebreaker for next meeting is going to have to be tell us your latest saga in the desert so we can hear Pam's story since we don't have time today.
All right.
Yeah.
I'll make a note.
Yeah,
Vacation breakdowns.
What are you binging?
yeah, you definitely don't have time today to hear it.
Yes.
I'm just glad you're okay. That's really
Oh yeah,
scary to me.
we were always fine. We were just kind of stuck out in the middle of nowhere for a while.
Well, it was really hot. I was a little bit
It's
nervous
hot.
for you because it was so hot. I was like, wow, do they have water? Is everything going okay?
Yeah. We've been in training too because we've been in the Grand Canyon, so we're pretty tough by now.
Pam, where were you?
We had vacation in the Grand Canyon,
Oh,
rafting, and then we were on our way back through Nevada, and the car broke down, kind of in the middle of nowhere, which is always kind of your Nevada nightmare.
Sorry. Welcome home.
Thanks.
All right. So we'll get back on track here. The commission is going to be engaging Milliman to conduct an actuarial analysis of our cost sharing options. So we would like all of FTAC members' input about the information that we'd like to get out of that analysis. So we are going to welcome, I don't know if both Ben and Peter are here from Milliman.
I think we're both on. Unfortunately, I don't think Ben's able to get promoted right now, so he might be listening only.
Okay, are you able to?
I don't see Ben in the room.
Yeah.
Unless he has a different code name is the
I'll pass his to you as soon as I can get it.
Okay.
But for now, it might just be me on talk.
All right. That sounds great. Thank you, Peter.
Sure.
I have Banco here too.
Yeah. Oh, that'd be great. In case he has anything that I skip over, he can definitely check me.
Sounds great.
Okay, I guess I can either share the document or I guess someone else who is screen sharing up. It might be nice to have those questions up that I'm going to go over.
Yeah, you can probably take down our slides.
I think, is this tab 6, Mandy?
Tab 6, yes.
Sure. I think our goal today is to get a bit of clarity around the, I guess, menu of pricing, the several pricing options that we can use to get started on our task of estimating the costs associated with the benefit scenarios we're talking about. So right here, and I should caveat what we have here, that we're not trying to guide the selection, but we did provide some examples to hopefully help folks think about the sort of information we're looking to get. But we're looking for definition around several benefit scenarios. Kind of pulled 3 out of the air as an example. And so these might be high level information that we can use to select benefit pricing for our pricing exercise here. Like, for example, Cascade pricing based on a Cascade Silver benefit plan, or Medicare-like benefit plan, or something similar like that. So at a high level, that would be a good starting point. We also know that there's interest in potentially adding some benefits that aren't necessarily covered in those several options I just gave. For example, maybe a dental benefit. To the extent there are additional services that want to be covered, we'll want to have those explicitly defined. So that would be maybe a maximum benefit would be a fairly standard approach for a dental benefit with some additional co-insurance. Something similar for a vision plan might be appropriate as well. And then on top of the benefit definitions that I kind of went through there, we'd also be interested in whether or not these are going to be a sort of fixed benefit structure, or if there's going to be any sliding scale that tries to adjust for the impact on consumers of different needs or different means. So again, based on the exchange benefits, we've got some examples here of how that could be structured. So that's the sort of information that we're going to need on the benefit side to get things rolling. I expect that there might be some fine tuning that we'll need to do. For example, if a Medicare benefit is selected, we might want to talk about how maternity services would be covered because of Medicare benefit not necessarily being appropriate for those services, for example. But that could be a starting point. I guess any questions there in terms of what I'm asking for?
I do see
Peter.
two hands raised. Oh, sorry,
Okay, sorry.
David. Gary and then Roger.
Thank you. So I think the commission has considered some of these already, and I want to throw out and then ask for members of FTAC, and particularly Pam, you, whether what I'm saying is consistent with what you think the commission has done so far. So I think that there's an interest in looking at Cascade Silver, the PEB-SEB plan, and I won't get right which one it is, but you all can help me which PEB-SEB plan it is. And I'm gonna mention Medicaid, but there's a question about Medicaid that I think I want to tee up for discussion. And then I think there's an interest in looking at adding adult dental to the Cascade Silver, because that's one of the things that the task force had looked that led to this commission being established, had looked at adding adult dental. And then I think that there has been discussion, but no decision, but certainly an interest has been expressed in some sort of sliding scale of cost sharing. But I don't think the commission has really defined what that would be. And so I think it would be helpful to see what that might look like if you all are able to do that. So Pam, does that sound about right to you based on the conversations because you've been in the meetings?
Yes, yes, it does sound right to me. Partly because I see that Roger's hand is up. I think in those selections, they aren't as refined as they could be. So as you kind of drill down and you have to do an actuarial analysis, there will have to be refinement that will make all of us more comfortable as we get to that. But I agree with that. And I think on the cost sharing, I feel like the commission is not very far along in that discussion. I think they've just kind of moved to the point where they're willing to entertain options in cost sharing. I think their preference of much of the group is no cost sharing at all. So part of the purpose of today's discussion was to get the juices flowing and get us thinking. But I feel like we still have a long way to go, and they need to do some thinking. I mean, one thing they may want to do is just establish some principles about cost sharing in terms of income or minimization or promotion of primary care. I think a lot of times things like that are done, and I think it's more. I don't know if that's our role or their role. I think our role is more to help them technically about what those cost trade-offs will be and what final cost will be. Does that sound right to you, Gary, as well?
I think that's right. I would just add, you've triggered my mind to add one thing. I think, and I may be going a little bit on a limb here, but I don't think I'm going too far out on a limb. I don't think there's a lot of interest in terms of cost sharing as a way to impact utilization. The question is,
yes, I agree.
I think the question is, if you eliminate cost sharing, then the cost of the system has to be borne somewhere else. So it's just a question of, in the context of a state-run uniform financing system, you're going to have a revenue requirement, and your revenue requirement for what's going to have to be paid for by the state and therefore collected in taxes, employer contributions, whatever the source is going to be, which the commission has not really gotten into yet. It's going to be higher if if consumers are not paying in a form of either deductible or at point of service care,
Right,
right?
right.
That's just sort of obvious. Yeah.
Right. I think we're all agreed that we want that to be as fair as possible, but we don't know exactly what that looks like yet. But I would underscore that I think in the 80s we believed that cost sharing would, help us control costs because people would be so much smarter about how they utilize healthcare. And that has gotten turned on its head now, which is that people are delaying or altogether deferring needed care because of cost sharing is so high.
Roger, you want to ask your question?
Yes, thank you. So as I've thought about what we're trying to provide guidance to the commission on at the end of the day is what is a per member per month cost? With coverage, cost sharing, et cetera. And from that, you do the math of the number of folks who are covered and then how you're going to finance it. But these are all somewhat separate and need to be distinct steps in my mind. The point is to start out with, I would like to make a proposal because it's not still clear to me what the commission thought that they were recommending. I don't mean this in a negative way. And let me begin by just a brief comment on where we see them talking about, the essential health benefits and cascade plan. From a benefit design perspective, those are the same plans. They have different cost sharing. They have different ways of reimbursing providers, but they're essentially a series of something like 67 benefits that our state has said that we will provide in the exchange. So when we're looking at this kind of stepping down through benefits, I would make a proposal and consideration that we use a term that Washington's essential health benefits, because that does include, cascade plan, all of those, and a consideration for adding in the benefits that our state is going to adopt for plan year 2026. There's 6 benefits that are going through the review process today and will be part of the plan design for 2026. So I'm just trying to say, from Roger's view, that's one set of benefits. The second set of benefits that I would suggest, and we've kind of talked about it, is what's covered by SEB and PEB. And they're essentially, this day and age, the same benefit design. And I think it's well covered in Washington's uniform benefit, the classic plan. I mean, that's the basis upon which all these other ones operate with. And as an add to that would be dental, because somehow in our world, we always treat dental as an adjunct. And I think more and more folks are saying, well, maybe, maybe not. And in Gary's conversation, you mentioned already on the essential health benefits, and maybe there should be a dental benefit to that. And then the third one, which is, I think, important as an anchoring point, is the Medicaid program. And I'm using some terms here a little differently. And that is what I mean by that is Washington's Medicaid programs for medical, behavioral health, and dental services. And in the Medicaid program, that bucket of things that we might want to call medical is broader in scope and duration than would be under that state employees get. And there's some specialty areas like EPSDT, for example, that gets kind of overridden, but there are additional medical benefits that sit in the Medicaid program. There is a significantly larger set of behavioral health benefits that are in the Medicaid program. And then there's the dental services. So what I'm trying to suggest here is a proposal. I'm just talking about the benefits, not point of service cost sharing, but just the benefits. There's 3. There's essential health benefits. There's uniform medical plan, and there's Medicaid, medical, behavioral, and dental.
Okay. I didn't totally grasp your proposal, Roger, and I think well, let me just suggest before you answer, I have a counter proposal, which is the way that I look at it, the differences between the total cost of care differences between those 3 packages is going to be smaller than, in a dollar impact, would be smaller than who's paying for the cost sharing. What I mean by that is whether dental is included or not, whether some of the new benefits are included or not. Let's say that's a plus minus 10% swing on the total cost of care. For a silver plan, we're talking about, does the beneficiary or member pay the 30% cost sharing? Does the government pay it? Does an employer pay it? To me, that's a big deal, and it shines a spotlight on some key questions that ultimately the commission is going to have to deal with. I think it might be more effective for this group if we ask Milliman to choose a single benefit plan, whether it's PEB or silver, and have them illustrate the cost, the actuarial value, and the dollar cost of the cost sharing for the commission. And we can expand and say, well, if we do this on a Medicare design or Medicaid design, here's what that picture changes to.
David, I guess I don't agree, because we don't even need Milliman to do that. You can sit there today in a nice chart and say, here's bronze, silver, gold. And our state doesn't offer platinum, but here's a platinum one. Here's what it looks like out of, that's those actuarial value aspects. I guess I think we need to do that, but I think what they're asking for, to some respect, is what services do we want to offer? Leave aside how much we got to pay for it, just for a second. And I keep coming back. I know we're not going to use all of Medicaid, and we long-term care is that, but it represents the broadest scope of services. I'm quite sure that the commission won't embrace all that, and that could be handled as supplemental coverage. But you have Uniform Medical, which is a robust benefit program, coverage for the large group and ERISA market, right? That's kind of large group ERISA. And then you have the essential health benefits. And those are three, I think, benefit design tiers to provide the array of cost options to help inform the commission.
Yeah, I appreciate your point, Roger, and I respect it. Let's see how other folks feel. Gary, you can go next.
So I just want to remind us all how we got to here. So it's been quite a few months since the commission has been asking for a comparison of what the benefits and services are in these different programs and what it would cost to provide them in a uniform system. We sort of promised that to them. I forget which month it was, but it was quite a while ago.
Yeah.
So, and in the context of what should the benefits and services be offered by the universal uniform system, and there was a feeling on the part of in the commission meetings that you can't really think about that without knowing something about what it would cost.
Right.
So cost sharing is a piece of that, but it's not the whole question. And so Roger presented a while back on, here are the benefits that are in Medicaid that aren't in the other programs. And Roger has some figures for what it costs the Medicaid program to provide those services to the Medicaid population. And then the question is, okay, so we know what it costs PEB-SEB, we know what it costs but what if we had everyone in the program at a particular set of benefits that we would agree on? What would that cost? Because that's the question we need to answer in order to know how to finance the system. Once we have what Roger says, what's the PMPM, what is the total cost? Then we can start talking about how we're going to pay for it, including taxes, cost sharing, premiums. I mean, we know there's a variety of ways of paying for it. So I think what Roger is suggesting, and I think it's probably a good suggestion, but I want to ask the Milliman people what they think, is in terms of how feasible this is. If we take benefits like long-term services and supports off the table, because we recognize that they are very expensive, and we say, no, we're not going to have long-term services and supports for the entire population that's covered by the uniform system, but we would like to see what would it cost if we gave everyone something better than what Cascade Care offers? What if we gave them the PEP-SEB plan? Or what if we gave them what Medicaid covers, and as Rogers termed it, for medical behavioral health and dental? What would that cost? And that will, I think, help inform the commission's decision on what's the set of benefits and services we want to recommend be included in the uniform financing system. Because if we don't do that, then we're going to end up with the same hodgepodge that we have now, with different people in the system being entitled to different sets of benefits. And one of the goals that has been expressed going way back to the task force is, to the extent possible, to have everybody who's in the system have the same set of benefits available to them. And the question is, what set should that be?
Yeah, thanks for that, Gary. When I reported out to UHCC and Pam Stead a couple months ago and heard Chair Lowe's concerns and some of the discussion at UHCC, the impression that I got is that this question of the magnitude of the cost sharing and the cost of eliminating the cost sharing was top of mind for the folks on the commission. So I think both questions are important and have to be answered. And so it's a sequential thing. Which one are we going to order?
I agree. No, you're right.
So David, let me try one for Peter. If I can. I'm sorry, and I promise I'll shut up.
Wait, Roger, sorry, hold on just one second. Let me just ask, since we only have 9 minutes left, Peter, do we need to go through the bottom 4 questions, or is that not as important?
I mean, for the conversation today, I think they're going to be a bit off topic.
Okay.
Those just to let folks know that we will have other questions coming. And some of these are covered by, I think, like the information covered in section 4 today, what populations will be covered, and whether that's going to be, required enrollment, or, people will be eligible to enter the system, that those sorts of questions, or what modeling scenarios we want. Not asking for answers to those questions today, but we will want them in order. So kind of, Roger, coming back to something you said, we do know a portion of the costs associated with different benefit structures. Say if you selected a Cascade Select plan silver level, what we would also need to look at is what that would look like if you sort of expanded that to include folks who are now enrolled in Medicaid or something like that. So there's an additional component there. Again.
Absolutely. Yep. And
okay, so sorry.
All I'm trying to suggest again is when, starting out with, these 3 benefit designs, and you folks have all the data. You're going to pull it together and say, I'm going to look at what it costs PMPM in a standardized rate across all of them. Pick 160% of Medicaid or whatever, Medicare, whatever you want to do, right? You just standardize that just to see what the benefit impact is. And then you overlay that and say, okay, we got PMs for all that. Now I want to start going through a series of point of service cost sharing. And one of those, right, is going to be no cost sharing at all. And then we go, and then we can come up with 3 or 4, standard cost sharing approaches. I would offer, for you folks to model, to take that back to the commission. I think they could understand that.
Yeah, that makes sense, right? And in fact, given that you and Gary feel the same way, I think I'll propose to the commission for your immediate reaction that we follow Gary and Roger's step first and not the one that I was proposing. So I'd like to hear, and Pam, you can go first and add your question on as well, but does anybody have a problem with following the direction that Roger and Gary laid out as opposed to what I laid out?
David, let me try again real quick. I'm sorry, Roger.
David, could you do a recap of what it sounds like you're maybe creating a motion? And I just want to do a recap of what you're thinking about.
Yeah, let me ask Pam to speak first, since
sounds great.
Your hands up.
Well, actually, I like what Mandy is saying, because I think that would be nice, and I'd actually like to, almost yield my time to some other people on the committee who haven't spoken yet, so we can also hear what they have to say. So maybe we could, you restate your idea in a motion, and then maybe we could hear from other committee members before, and then I can chime in later.
And
Okay.
David, if you want Gary to phrase that motion for you based off what he had said previously, feel free to pitch that to Gary. I'm sure he would do that for you.
Gary, if you'd be happy to do that, I'll take you up on that.
So I think what we're asking for is a comparison of the benefits that are provided for in a Cascade Care Silver plan, in the PEB-SEB plan, and in the Medicaid plan. But we're going to have to modify Medicaid to make sure we're looking at the core. I think the way Roger phrased it is probably right, but we have to look at specifically which benefits we want to be modeled, right? Not including long-term services supports, but and adding adult dental to the plans that don't have that, and look at and try to model those if those were provided to the entire population that would be covered by a uniform financing system, so that we can see what the costs would be. That would be step one. And then step two would be to model different options for cost sharing. And I think we have to provide Milliman with some more detail on what those should be. I don't think we can do that in the next few minutes, but I think that's the concept. Does that sound right?
Great. Yeah, that sounds good, Gary. I saw Eddie's hand go up. Eddie, did you want to make a comment?
From Peter's standpoint, the cost sharing, is it just a sliding scale that you can apply to the analysis you give back to us, where you can just move that number and change the PMPM to shared cost versus cost savings?
I guess are you talking about if you have different cost sharing based on a means test, or are you talking about just the outcomes of these several scenarios?
Yeah, so once we define the benefits plan, then if you want to have no cost sharing, then the opposite would be, how high do you want cost sharing to go in some reasonable range? But if you slide that over, you would see that, your shared cost would drive up the PMPM, or actually the other way around. But so to speak, can that be given to us in the form of what we're asking for?
Yes, to an extent. I think that there will be some impacts of shifting utilization. So you might imagine that folks will select into outpatient service for surgical services and out of ASC. So it won't be as straightforward as that. As in, you can't just sort of make a straight adjustment. We would expect utilization shifting to also occur. And so provide a menu, but it's not going to be like a linear relationship across the different services, if that makes sense.
Oh, totally. Yeah, the low utilization versus high utilization and cost sharing there, and versus shared cost. Yeah, that was a great little chart. But sorry,
Right,
yeah, thanks.
Yeah, thanks, Eddie. Christine?
Yeah, I just had a clarifying question about modeling Cascade Silver, and it wasn't clear to me whether that would be really a 70% actuarial value plan for everyone, or if we were building in the cost sharing reductions for the lower income population in that sort of part and parcel of the Silver plan.
Gary, you want to comment on that?
My recommendation, Christine, would be to model based on current law, which is that the enhanced benefits are going to go away after 2025.
Well, right, but the enhanced benefits, but the cost sharing reductions don't go away after 2025.
Right. So I would include those.
That. Okay.
Yeah.
All right. Roger, I can give you 30 seconds. I think we have to squeeze in a vote also. You're on mute, Roger. Roger, can you hear me? You're on mute.
Excuse me. We're talking about the Cascade Silver Plan. I want to try this one more time again. The benefits in the exchange are the same across all of these things. Cascades is standardized benefit cost sharing, and the select has the public option one. But I think what we want to tell back to the commission is, here's the benefits. forget about cost sharing for just a minute. All that is, it's critical, but the benefits we were suggesting to model is the essential health benefits. And I would argue that the ones that are going to be in place in 2026, because that's where we're going to be very shortly. There's the state employees, uniform medical, and then, the Medicaid and the other one. When we bring in Cascade Silver, we're introducing cost sharing at a point we don't want to introduce it yet. And it's the same as all the others ones with respect to the benefits in the exchange. It's the essential health benefits.
Yeah, I think that's clear. I think
So
I think it is. I think so too.
okay. Am I clear or Gary's clear?
I think you're saying the same thing.
I think we should, maybe we should move.
Yeah, I think we have
restate
to
it,
wrap
maybe
up.
have restated or move ahead to
Yeah, so I propose, and Mandy, tell me if I'm doing this wrong, but I propose that we adopt the approach that Gary articulated a moment ago.
That works.
Okay. All in favor, say aye. Aye.
I
Aye.
All opposed, say opposed.
Aye.
All right.
For the reasons I stated. I think
Okay.
we're confounding things.
So
Okay.
I
Pam?
raised my real hand by mistake. I would, if we could do this is maybe a request to staff that if we could get Gary's proposal kind of in writing. I think that might help with some of the if there was a little bit of confusion in this meeting, I think that would be helpful.
I think we can do it in a way that addresses Roger's concern.
Yeah, because I want to have as much specificity and clarity about the decision we just made.
Thank you.
Okay, so
Good
Pam, do
idea.
you want to hold this? Do you want to consider passing or clarifying, or do you want to hold the vote until?
No, I'm fine. I think we understood.
I think it passed. We'll just send it out.
Okay.
Yes.
To not confirm the vote, but just to make sure we captured the vote appropriately.
Correct. What Mandy said.
Okay, great. So that proposal passes. Thank you all for a spirited and productive meeting. Thank you for our public commenters. Thank you for our HMA guests and HMA staff support, and of course HCA staff support. And our next meeting is on September 4th. This meeting is adjourned.
Thank you, David, for your wonderful sharing
Thank you,
today.
David.
Great job.
Great job, David.
Thank you. Thank you.
Thanks, David.
Thanks, everyone.
Thank you.
Oh dear.